Hello, my name is Nadeem Abu-Rustum. I'm a gynecologic oncologist, and I'm going to cover aspects of fertility-sparing surgery in gynecologic tumors. The three most common gynecologic cancers that we treat are cervical cancer, endometrial cancer, and ovarian cancer, and I will review quickly the options for fertility-sparing surgery in each of these tumors. We're going to start with cervical cancer. Now we have guidelines that are nationally accepted to offer fertility-sparing surgery for select young women who have small tumors of the cervix to preserve the uterus, avoid hysterectomy, cure the cancer, and still allow for the ability to carry a child and deliver a healthy term pregnancy. These are usually selected cases based on very small tumors where there's no evidence of cancer outside of the cervix. The smallest tumor that this would be eligible for would be something called a stage 1A1, and that can be treated with a procedure called a conization, where it's basically a large biopsy of the cervix to remove the cancer, get clean edges around the cut edge of the conization, and then the uterus can be preserved. Sometimes we combine the conization with the removal of lymph nodes by a technique called sentinel node mapping, where we inject a dye into the cervix. The dye will guide us to the most important lymph node. That's a colored lymph node seen here. This lymph node is removed by laparoscopy, and then a conization is done. Patients can usually go home the same day, recover for a couple of weeks, and that would be fertility-sparing treatment for the small cervix cancer. If the cancer is a little bit larger, then we would have to do a slightly bigger operation called a tracheotomy, where you actually have to remove the majority of the cervix, sometimes the entire cervix and the surrounding tissue. And that's done for when the stage is slightly higher. This is also accompanied by removal of lymph nodes. And again, we can carry the same procedure now to a higher stage called stage 1B1, where the tumor is bigger in the cervix. And that would be the maximum stage that we would offer fertility-sparing surgery for. Beyond stage 1B1, it's very difficult to preserve the uterus and preserve fertility. But many patients who come in with stage 1 cervix cancer, who are younger than 43, who want to preserve fertility, these procedures can be worked up and offered and can be successful in many patients. This is again a diagram showing you the area where the procedure will be done to remove the cervix and avoid removal of the uterus, tubes, and ovaries. Again, removal of lymph nodes in the pelvis is a very important part of many of these cases, and this is usually done minimally invasive using a sentinel node mapping technique where you inject a dye into the uterus that will guide you to the most important lymph nodes, so you can remove these lymph nodes and avoid removal of a lot of lymph nodes that can result in leg and foot swelling or lymphedema. Tracheotomy basically is to remove the cervix, preserve the fundus, and these images are going to give you an idea of what's removed. And then we reconstruct the cervix. We put a cerclage. This will help hold the baby during pregnancy so the mother won't have a miscarriage. This is a permanent suture that stays in, and then the mom delivers by C-section. Again, the uterus is reconstructed back to the top of the vagina. So this was a summary of what can be done for cervix cancer. Moving on to endometrial cancer, this is a little bit different cancer. And again, you can see from this diagram that women are delaying first birth and first childbearing because of change in culture. Women are working more. They're preoccupied with their jobs and education, and they're delaying childbearing. So you can see here that the percentage of women having children later on in life after 30 and after 35 is increasing with time. So again, as you delay childbearing, you run a higher risk of developing uterine cancer. Of course, obesity is also increasing in our society, and that also is another risk factor for uterine cancer. So when we see somebody with endometrial cancer, we have very strict criteria to select patients that may be candidates for uterine preservation, and it's a very strict list, and I'll go through this list. The tumor has to be the least aggressive type, called the grade 1 endometrioid. That's determined by a pathologist. The diagnosis has to be done at the time of a dilatation and curettage, DNC, and hysteroscopy, not just an office biopsy, but a full scraping of the uterus. The pathologist has to really review the entire specimen, and it's best to have an expert gynecologic pathologist that will give you the best diagnosis and avoid a misdiagnosis. You have to make sure that the family history is not suggestive of a familial cancer syndrome such as a Lynch syndrome. This is a syndrome where you can have uterus cancer, colon cancer, ovarian cancer, urinary tract cancer. And again, if the patient fits into that syndrome, fertility-sparing surgery is probably not a reasonable option. Of course, we do a pap smear and we check a CA-125 to make sure that the cervix and there's no high risk for metastasis outside of the uterus. And again, it's very important to obtain a pelvic MRI, a magnetic resonance imaging. This is a very important test to make sure there's no invasion of the tumor into the muscle of the uterus, because that would be a contraindication for fertility-sparing surgery. And we always get a consultation with a reproductive endocrinologist and a fertility specialist to make sure the patient has a good potential for reproduction. And then if she's going to go through this fertility-sparing management, that she actually does have a reasonable chance of conceiving in the future. So obtaining an MRI is a standard of care for us. And again, consultation with infertility and reproductive endocrinology is also a standard of care, because you want to make sure that the patient does have good fertility preservation potential before she commences with uterine preservation. Once all these are achieved, then we can attempt uterine preservation. So again, in summary, it has to be a grade 1 endometrioid histology, age less than 43 usually, no muscle invasion by MRI, no obvious metastasis by MRI, no evidence of Lynch syndrome, very strong desire to avoid a hysterectomy, and again, no absolute contraindication to treating the patient with a progestin, because that would be the treatment, either a progestin tablet, injection, or an IUD of progesterone. And again, consultation with infertility specialists to make sure that there is good potential for reproductive function. The treatment with progestin can last sometimes up to 6 or 9 months or sometimes a year. So we want to make sure that the patients have seen the reproductive endocrinologist and they do have a good potential for conceiving. The treatment is usually not surgical. It's usually done by a progesterone medication, either a tablet, an injection, or an IUD placed inside the uterus. And then resampling is done at 3 months, 6 months, 9 months until the pathology clears, and then the patient's allowed to conceive. If there's failure to regress the problem, then hysterectomy is usually considered. Moving on to the third cancer and the last gynecologic cancer that we're going to discuss, these are ovarian tumors, and they fall into 2 categories, something called a borderline tumor or a low malignant potential, and then the obvious invasive ovarian cancer. And clearly, the obvious invasive cancer will be much more difficult to do fertility-preserving surgery. The borderline tumor is much more amenable to fertility preservation. Conservative surgery for ovarian tumors usually removes one side, like one tube and ovary, or just the cyst, and preserves the other side. And then you have the option of freezing eggs or freezing embryo from the preserved ovary, either the contralateral side, or sometimes even if you preserve half of that ovary, you can obtain eggs from the remaining ovary. The surgery options are usually to remove just one tube and ovary or remove the cyst alone, but if you remove the cyst alone, it carries a higher risk of recurrence in that same ovary. If you remove both tubes and ovaries, then of course you would need a donor egg, or if you have eggs or embryos frozen, then they can be placed back into the uterus. In general, for borderline tumors, if there's no obvious metastasis, then you can remove one adnexa, one tube and ovary, preserve the uterus and the other side, and that can be successful in many patients. If you have an invasive cancer, then you have to be very careful with strict criteria to make sure you're not putting the patient at risk. In general, we would offer fertility-sparing surgery for young women who have cancer affecting only one ovary that's absolutely determined to be stage 1 with no obvious spread. Those would be the best candidates for fertility preservation. If you need chemotherapy, it may also affect the remaining ovary, may compromise fertility, but it has been shown in studies that in younger women, even if they receive chemotherapy for certain types of ovarian tumors, fertility can be preserved. So this was a summary of the 3 most common cancers: cervix, uterus, endometrium, and ovarian cancer. And again, today, we have newer technology, and with the help of pathology, radiology, and better imaging, we can preserve fertility in many patients who present with this disease. Thank you very much.